Acute pulmonary edema due to CHF is something that students have trouble understanding. This occurs when the heart stops working efficiently, most commonly due to an MI or some type of hypertensive emergency. And the heart can't pump blood well enough, so the blood returning to the heart that's supposed to be pumped out to the body once it's oxygenated, it backs up into the pulmonary circuit, and the usually strong left ventricle begins to tire out and it craps out. Think of the heart like a sump pump in your basement. If there is water coming into the basement and the pump craps out and is working at only 40%, the basement's going to start to flood. As blood is backing up into the pulmonary vasculature, the vessels are getting distended and the little capillaries have tremendous pressure exerted on them. As the vessels get too dilated and the pressure inside of them is too great, they become porous and the liquid components of the blood begin to seep out of the vessels and into the lungs, which floods the alveoli and prevents gas exchange. But it gets worse. The body senses a problem and it signals the kidneys to jack up the blood pressure, causing more sympathetic stimulation, which creates tons of afterload for that already gassed left ventricle to have to push against. And then more blood backs up because the left ventricle's even more crapped out, and the vicious cycle continues. You need to be aggressive when you treat these patients and go in guns blazing. First, sit them up. Make gravity work for you and let that fluid pool in the dependent areas of the lungs. Then you need to correct the hypoxia, and we do this with CPAP. This provides PEEP that recruits alveoli, stents them open, increases the surface area available for gas exchange, which makes the alveoli not as flooded. You need to decrease preload, which is the amount of blood returning to the heart. This gives the heart a break so it can quite literally take the load off for a while and get some well-needed rest. That CPAP thing we put on initially for hypoxia, well, it also very effectively is going to reduce preload because it increases the intrathoracic pressure. This puts pressure on the heart, especially the wimpy right side of the heart that pulls in so much blood from the vena cava and prevents the heart from sucking in so much blood from the body. Then we use nitroglycerin, which is a vasodilator. You relax the blood vessels, you make them bigger, and this decreases the amount of fluid that is going back to the heart. Nitro is very safe to use in these patients, and it's very effective. If you have IV nitro, that's awesome. It's phenomenal, but sublingual works just fine too. Nitro and CPAP will also decrease the afterload, which is just the blood pressure that the heart has to pump against. You want to decrease afterload to further help the heart with taking a load off. Some projects will also give an antihypertensive like enalapril, but that tends to be more in-hospital stuff. Diuretics are a mainstay therapy in volume overload CHF. They have mostly been taken out of EMS protocols as they typically aren't a first-line intervention for heart failure, and depending on the etiology and overall fluid status and fluid distribution in the patient, they could actually make things worse. Also, studies show that all disciplines of healthcare provider suck at differentiating causes of respiratory distress. So if the dyspnea is not due to heart failure and it's something like pneumonia or a dehydrated COPD patient, you may make them much worse if you give them a diuretic. This is why you always have to do a very good physical assessment and history taking. And that is the basic EMS approach to the patient with acute pulmonary edema due to congestive heart failure.